our grand round speaker this morning. I'll let Dr. Ramirez actually introduce it. It's a very timely topic with Zika virus. I was sharing with Dr. Ramirez that I'm planning a trip to St. Thomas in April and luckily I can't get pregnant, but I am a little worried about going there. So I think it'll be interesting to hear what we have to say about this and how it might impact us. So Dr. Ramirez.
Good morning. Yeah, the idea initially, when we have this grand round scheduled for a long time, we were planning to discuss some issues related to our research and in pneumonia. But then in the last couple of weeks, we started to get so many questions and so many issues in our travel clinic that we developed, the group got together to see what's going to be our advice to the Louisville community. And then we thought that this was probably the best thing to move this grand round to the topic of Zika infection. The grand round was supposed to be given by Dr. Raghuram and Dr. Carrico. Now Ruth, that is also running our travel clinic, had a meeting yesterday in Houston, yesterday morning, and she's still in Houston. Every flight to Louisville was canceled. Well, as a matter of fact, she's flying back. She's going to be around here at 9 o'clock for questions and answers. Then the grand round that was supposed to be between two members of our 550 clinic is going to be just one member. And Anu is the medical director of the 550 clinic, and our travel clinic is in the 550 clinic. Then Anu is going to give the presentation, and our goal is to have at least 10-15 minutes for questions and answers at the end. Anu?
Good morning, everybody. It's a pleasure to be here giving you an update on Zika virus infections. So today's objectives for this talk is to basically review epidemiology, pathogenesis, clinical manifestations, diagnosis and management, and we're also going to look into transmission and prevention strategies. So let's start off with two cases. This is going to become something very common, I would say, in the next several months. But let's look at these two cases. So we have my bad. Okay, so this first case is Mary. She's a 26-year-old physician. She just came back from a mission trip to El Salvador 2 days ago. She's asymptomatic, but she recently learned that she's 6 weeks pregnant. Second case is Edith. She's 34. She was in northeastern Brazil for a vacation, and she just returned 2 days ago. But now she's got fever, conjunctivitis, and a maculopapular rash. So what do we do with these folks? So let's understand a little bit more about these infections and see what the management will be. So let's start with what Zika virus is. So this is a flavivirus, and just to refresh your memory, other flaviviruses are dengue, yellow fever, West Nile, and Japanese encephalitis. Chikungunya, although has a very similar clinical presentation to dengue and Zika, it is not a flavivirus, but it shares the same vector, okay? This virus was actually initially identified in 1947 in the Zika forest of Uganda. This was detected in a monkey. They were actually doing studies for yellow fever, and that's where they found the virus. And the first human cases were described in Uganda and Tanzania in the 1950s. So what about pathogenesis of this virus? So viral tropism was documented way back in 1952 when this virus was first identified. And there's a complex pathogenesis involving autophagy. And there's two clades of virus, one from the African lineage and one from the Asian lineage. So let's explore how this works. So let's look into autophagy and what happens. So let's say you have an abnormal protein. There's your cell. There's your protein. And what typically happens is this abnormal protein is going to be enclustered by the autophagosome. And then comes your lysosome, and it is going to then join that autophagosome to form a autolysosome. And what's the objective of all this? So it's going to basically do a housekeeping role. It's going to clear this abnormal protein, and following that, you're going to have release of those fragments. And so basically, you're having a housekeeping role in removing these damaged proteins and eliminating intracellular pathogens, okay? Now, what happens with Zika virus? So you have your Zika virus, and there's a receptor on the cell. You're going to have endocytosis. Virus is going to enter the cell, and you're going to have that same process, basically. It's supposed to be incorporated into the autophagosome. And the next step would be your lysosome, right? However, the Zika virus and other flaviviruses have the capacity to stop this step. So the lysosome is unable to join with the autophagosome. So essentially what you have is viral replication now in a very protected environment, okay? So you have essentially mini viral factories here. So you're going to have your replication and your assembly and your release, and there you go. So this is the proviral process that happens with all these viruses, Zika, dengue, and chikungunya. All right, so let's now look into what's going on in the world, right? So as you can see here, this is a depiction of all the places where Zika virus has been over the years. You can see that this is in a belt sort of distribution along this area. You see that there's not anything up here, not anything down there. This all has to do with the vector for infection. Those are the climatic conditions that this vector needs to be successful. So if you look here, first identified in Uganda, you see some sporadic cases here and there. And then more recently, in 2007, you see outbreak in Yap Island in Micronesia. There was about 180 cases. And then more recently in the French Polynesia, Tahiti, there was an outbreak. That was a larger epidemic. We're talking about 30,000 plus cases. And then you can see some cases in New Caledonia and Easter Island. And of course now the hotspot is in Brazil. Okay? So what are the countries that have active Zika virus transmission? So you see pretty much most of Latin America, Central America, you see some islands and some spots here and there. What about in Latin America specifically, which has been the greatest number of cases in the world? So of course you see Brazil heading the case count here, more than 1.5 million cases at this point, followed by Colombia and Venezuela. Of course in Central America, Honduras and El Salvador have the greatest number of cases. This is just a summary slide, just outlining the different outbreaks. We already talked about these, mainly the Yap Islands and the French Polynesian outbreaks. And what about the outbreak in Brazil? What's going on there? So this outbreak has been reported from May 2015 to present, although even late through 2014 there may have been some cases. We're talking about 22 out of 26 states affected. And this particular virus that is in the Latin American outbreak is from the Asian clade, okay? And there's a lot of speculation of how this virus actually got introduced to Brazil. One was, of course, the 2014 Soccer World Cup. For those who follow soccer, you probably know that there's not a lot of Pacific Islands competing, so there were none here. However, at the same time, there was an international canoe racing event, and there were 5 nations from the Pacific Islands competing at that time. That is not to say there weren't visitors from the Pacific Islands that came to the Soccer World Cup, of course. So right now there's a debate of what introduced the virus to Brazil, but these are the 2 most considered hypotheses. What about U.S.? What's going on in the U.S.? So right now, as of February 10th, we're up to 52 cases. The week prior, it was about 35. In the continental U.S., all the cases are travel-related. In territories, however, Puerto Rico and U.S. Virgin Islands, we do have local transmission. But so far in the continental U.S., it's all been travel-related cases. And what do you see in Zika virus infections? So the incubation period is short, 3 to 12 days. The viremia is very short-lived. It's about a week. It's a self-limited mild illness, about 2 days to a week. And remember, 80% of people are actually asymptomatic, okay? So 4 in 5 people are going to feel absolutely nothing. And what are the main symptoms that you see? So fever's there. Seems like rash and conjunctivitis are more prominent. Arthralgias and myalgias are there, but mild when you compare it to dengue and chikungunya. These two pictures here, this is from a case report from 2015, and you see a very nondescript maculopapular rash. I'm not sure how well you can see it there. And this picture down here is somebody we saw in clinic a couple weeks ago with the right clinical syndrome and the right geographic exposure. And we are anxiously awaiting the test results. But you see this very prominent conjunctivitis here. In terms of clinical manifestations, neurologic complications are key here. We talked about viral tropism for the brain. What about microcephaly? This seems to be the big hot topic in everywhere you look, social media, internet. So first of all, I want to say that microcephaly in itself, as most of you already know, is not a disease. This is a manifestation of something that went awry in the brain formation in these babies. So what the constellation of things that you will see are coarse and diffuse calcifications. You also notice severe damage of cerebellum, brainstem, and thalami. The damage that you see seems to be very similar to West Nile virus, which is another flavivirus, but it is more severe than what we see in CMV, which is not a flavivirus, right? But this is what we traditionally think of as a cause for microcephaly. And the characteristic nodules for toxoplasmosis are not seen in these babies. Just so you have an idea of what is seen on ultrasound, okay, this is from Brazilian cases, ultrasound findings. So right up here, you see calcification. You also see dysgenesis of the corpus callosum. And here you see a very widened interhemispheric fissure, and again, calcifications. So that's kind of what you see on an ultrasound. And these changes are going to be apparent in the late second into the third trimester. So these are not changes you're going to see very early on. And why is it thought that this is connected with Zika virus? Because we've recovered Zika virus RNA in 4 severely affected fetuses and perinatal deaths, 2 amniotic fluid samples, 1 placental sample. And retrospectively, because first the whole buzz was like, well, why is this only happening here in Latin America? We had an outbreak in the French Polynesia before. There was no cases of microcephaly. So when they retrospectively looked at the data, they actually did see an increase in the number of cases of CNS congenital malformations and microcephaly in the French Polynesian outbreak. And this article, maybe some of you are familiar with it, came out just February 10th in the New England Journal of Medicine. This was a case report. This was a mother who lived in northeastern Brazil during her first trimester of pregnancy. She fell ill with a clinical syndrome consistent with Zika virus in the 13th week of gestation. She then returned to her home country at 28 weeks gestation. And at 29 weeks, when they did the ultrasound, they saw brain calcifications, very blurry brain structures, a very malformed brain. This mother elected to have termination of pregnancy at that point, and they did do an autopsy on the baby. So what they found was actually they were able to sequence the complete genome of Zika virus in that autopsy material in the brain, and the PCR for Zika was positive. And actually on electron microscopy, they were able to see virion particles. So this was pretty compelling evidence that that's what was happening to this baby. And these are the pictures, as you can see here, dotted with calcifications, very blurry structures, malformed, and right here you can see a big calcification. So this was pretty compelling and dramatic evidence of Zika virus infection. And in terms of other neurologic complications, we are aware of Guillain-Barre syndrome associated with several other viral infections and otherwise. So this is something that has also been linked even in the past to dengue infection, and now even with Zika virus infection. So if we look at the pathogenesis of Guillain-Barre, you see that what happens is you have an antecedent infection and you have molecular mimicry. So what happens is, in here Campylobacter is depicted, but basically you're going to have proteins in the bacteria or the viruses that are going to mimic certain things that we have ourselves. So there's ganglioside mimicry, and you're going to then produce antibodies which can then attack our own peripheral nerve, leading to the syndrome. So this is a bizarre autoimmune response to an antecedent event. And now let's look at the data on Guillain-Barre reports related to Zika. So here you see that in the French Polynesian outbreak, there were 42 cases noted, and that was a 20-fold rise in rate. And this was noted at the time of the outbreak. This was a link made back then. This was not retrospective. Right now in Brazil, 121 cases that had a history of rash illness, and 62% of those had a clinical syndrome consistent with Zika. In El Salvador, between the period of 1 month, you had 46 cases and 15 cases so far in Venezuela. What about ophthalmic complications? So they have found these changes in babies, so 13 infants that had microcephaly and presumed vertical infection in Brazil. The mothers did not have any ocular lesions, and they were not at that time of these findings viremic. But the findings in the babies included macular chorioretinal atrophy, macular pigment modeling, and optic nerve hypoplasia. And this is just illustrations of those two conditions. So here you have modeling of the macula, and here you have macular atrophy. What about diagnosis? So diagnosis is very challenging for these infections, because remember I told you the viremia is very short-lived. So if you're not within that first week of infection, if it's after that, your serum PCR is probably going to be negative. And of course, so negative results on the serum PCR are not going to allow you to exclude an infection. So what are we left with? We are left with serology, which we all know is very unsatisfying as well. So after 4 days of symptoms, you should check the IgM antibodies. Now remember, the other flaviviruses can cross-react with Zika, so then you're stuck with comparing titers. So your titer of Zika antibody has to be 4 times greater than your dengue titers for you to be pointed in the direction that this is Zika, okay? You should also check paired titers, acute and convalescent. And unfortunately, there's also cross-reaction if you've had previous yellow fever vaccine or Japanese encephalitis vaccine. Currently, the tests are being performed through the CDC and 3 health departments, so New York, California, and Florida. Here the process is we call the state health department in Frankfurt, and there's a contact there. There's several forms to fill out, and then they're our go-between in our liaison with the CDC. But very soon, we hope that this test will be commercially available. And just to reiterate, I think I did not mention this before. Right now, the CDC is testing everybody, male or female, female pregnant or not pregnant, that has been in a Zika area within the last 2 to 12 weeks. Okay. And how do you differentiate this from the other 2 entities that are very similar? So chikungunya and dengue are very similar in presentation. It's just some things seem to be more prominent in Zika as opposed to the other 2. So one of the things that you see is the fever in dengue seems to be more prominent, but again, very present in both these other entities. Myalgias and arthralgias seem to be less prominent in Zika, much more so in dengue and chikungunya. In chikungunya, in fact, the arthralgias can last for months. And then the other thing that you see more prominent in Zika is the rash. And of course, the conjunctivitis, which is very rarely seen in the other two entities. The more serious things, thrombocytopenia, leukopenia, are not really observed in Zika. Okay. And what do you do for these patients? So the acute illness is just supportive care. There is no medication, no antiviral for this right now. And the main concern is with pregnancy and congenital infection. Of course, in many of these areas, you have dengue co-infection, so you should avoid use of NSAIDs. So let's return to our first case. This is Mary, the 26-year-old physician who just came back from El Salvador and is feeling completely fine. However, she just learned she's 6 weeks pregnant. So what do you do with this person? So first of all, this is the most recent guidance from the CDC. So if you're pregnant and you travel to a Zika area, you have to, of course, test for Zika. If it's negative, remember that the viremia is short-lived, serology is unsatisfying. You still should monitor that baby with serial fetal ultrasound, okay? If at any point, and you're going to see this more in the late second to third trimester, if you see intracranial calcifications or microcephaly, you should retest mom and consider an amniocentesis more to establish the diagnosis. If the ultrasounds are all okay, you just go on with your routine prenatal care. Now, if mom tests positive or inconclusive, which we will come across, right, monitor the baby and consider amniocentesis. What about the other case? So that was Edith. She's 34. She was in northeastern Brazil, and she returned 2 days ago and now has fevers, myalgias, and a rash. So obviously you're going to test for Zika, right? She's been in the right place at the right time, and she's, of course, symptomatic. And you have to check for pregnancy and supportive care, okay? And if she is pregnant, we're going to fall back into that same algorithm I just showed you, all right? What about if you're pregnant and you live in an endemic area, right? So this is a very busy chart, but the summary of this is test for Zika, monitor the baby, and repeat, okay? So that's the sequence of events. You're always checking those ultrasounds. And of course, this sparks always the concern and the debate on termination of pregnancy, on some countries where you can do that, some countries where you can't. So this is a situation of many difficult decisions to be made. What about the babies? When do you test the infants? So if you have an infant that has microcephaly or intracranial calcifications and mom was in a Zika area during pregnancy, you're going to test. Or mom was positive or inconclusive for Zika, you're going to test for Zika. And of course, you have to do a comprehensive evaluation because you're looking for any other cause that could explain these findings, including the traditional torch organisms that we always talk about, toxo, rubella, CMV, and HIV. Of course, you're going to have to maybe look into genetic causes, look in the eye, peds neuro, and your routine labs. And what do you test in the baby? So in the babies, you're going to test serum, and if you're working them up for febrile illness, little babies, when they're admitted, they automatically usually buy an LP. So if you're going to do an LP, send it for that. And you're going to do PCR and antibody testing. For placenta and umbilical cord specimens, go to histopathology. And obviously, mom, if she hasn't been tested yet, test her, okay? Now we're going to move on to the next part of the talk where we're going to explore transmission and prevention strategies. So we have two other cases for you. Case 3 is Cora. She's 23. She's 24 weeks pregnant with her first child. She's going on a baby moon to Jamaica with her husband and family. And you guys know what a baby moon is, right? Before you have the baby, you go and have a vacation because you're never going to sleep ever again. So that's what it is. Very popular these days. And Cora's sister, who's going with her, she's 8 weeks pregnant. And she's coming to your clinic, and you're supposed to counsel her on what to do. The other case is Robert, who's a 38-year-old male. He's planning to go to the Dominican Republic for 2 weeks for work. So it's not an option for him to not go. And he's concerned with the risk to his wife and because they've been trying to conceive. So what do you do in these cases? So let's look into Zika transmission. Where has this virus been isolated so far? So in the blood, CNS, saliva, urine, placenta, amniotic fluid, and semen. And how long does the virus stay around in these places? There are a lot of unknowns, as you can see in the chart. In the blood, we talked about it being 1 week or less. CNS, we don't know. Saliva seems to be similar to blood. And they did a study actually in the French Polynesia looking at detecting Zika in saliva. And it didn't seem to stay longer than the blood. Urine looks like maybe 10 days or more. Placenta and amniotic fluid, we don't know. And semen, we have 3 case reports, and we know at least 2 weeks, but we don't know anything beyond that. So how is this transmitted? So mosquito-borne, vertical transmission, sexual transmission. I talked about 3 case reports, people who were in Zika areas, came back. The partner is then infected and had no other travel outside or any other known exposure. And of course, there is the risk with blood transfusion. If patients are asymptomatic, 80% of them, and if you go to be a donor and you're feeling fine, you might still be viremic, so there's a risk there. And what about the mosquitoes that transmit this? Who should we be worried about? So we should be worried about Aedes type mosquitoes in terms of them transmitting chikungunya, dengue, and Zika. So there's 2 types of Aedes that are actually here in the States. One is Aedes aegypti and one is Aedes albopictus, or Albopictus, sorry. And these are all daytime biters. They're aggressive daytime biters. If you look at Culex mosquitoes, which transmit West Nile, they're dusk to dawn biters, and Anopheles mosquitoes that transmit malaria are dusk to dawn biters. And so where are these guys in the U.S.? So if you look at Aedes aegypti, which is traditionally the more efficient transmitter of disease, kind of hanging around the Gulf Coast. And you see Aedes albopictus has a much wider distribution in the U.S. And can Albopictus transmit Zika? So the answer is yes. There actually has been a proven outbreak in Gabon, Central Africa, where the Albopictus, which is more predominant here in the U.S. Than the aegypti, transmitted the Zika virus in an urban environment. And what is the life cycle of these mosquitoes? So if you start out with an egg, you can see how teeny tiny they are, right? They need a very thin film of water, like the thickness of a dime maybe, to lay those eggs. Once those eggs are laid, they're going to evolve into a larva, and these larvae stay on downwards, and this is the surface of the water right here. And then they evolve into pupae inside the water still, and after that is the adult stage. This whole cycle varies. It can take from 10 to 12 days. And remember that only the females bite you, right? Because they need to nourish their eggs. So the males don't bite. They die quickly after they mate. And the females stick around, and they're the ones who are going to bite you during the day, right? And the females actually survive for about 3 weeks or so. So let's go back to our case 3, which was Cora, who was the lady going on the baby moon, and she's already 32 weeks pregnant, and she's going with her sister, who is 8 weeks pregnant. So what do we do with Cora and her sister? So if we were to counsel her in our travel clinic, we would say don't go. We just don't know enough about it seems that the first trimester is the greatest risk, but we don't even have enough data to know for sure what the consequences would be later on in pregnancy. So we would say don't go. But if they insist and they must go, what can you counsel them about? So you can counsel them about insect precautions. There's different types of repellents you can use. DEET is the commonly known one that you can apply. If you use it the way it's on the label, it should be safe for pregnancy. Don't drink it or do anything else with it. But other things you can do is permethrin, not on you, but on gear, mosquito netting, bedding, clothes. You can do permethrin on those, okay? So you can try that in long sleeves, pants, try to protect yourself as much as possible. Again, good luck with that in those very hot climates, right? But again, our main recommendation would be to say, don't go. And what about vector control? That is a big issue in all these countries in Latin America. So insecticides has been the traditional thing. You're probably familiar with fogging, you know. I'm from northeastern Brazil, actually, and that was part of growing up, fogging, and so that's one strategy. The other strategy, and you might have seen a buzz about this in the media too, about genetically modified male mosquitoes, so that when they either can't, they're not going to breed viable offspring. So there's two ways they do that. One is irradiating the male mosquitoes in the lab and then letting them loose. The other way is actually genetic modification therapy, where it's a very sophisticated way of turning on a gene, a lethal gene, that can happen on later. So the male mosquito that's modified can actually mate with the female, but the offspring are not viable. So have they actually done this? Well, they actually studied this in the Cayman Islands in 2010, not for Zika, but for other viruses. And they reduced the mosquito population by 95%. And in Brazil, probably around July of last year, they experimented with this in one city in Bahia, in Juazeiro, and they also noted a reduction in the mosquito population there. But that was the only place I know that they tried this as of yet. And of course, vaccine development is then the next big question and step, because if we can develop a vaccine for this, we wouldn't have to worry as much as with all the other factors. Of course, we still need to do all that, but this would be great. And that is in development. Timeline is not known yet. Some people very optimistically are saying by the end of the year. Most likely it's going to be 3 to 5 years, okay? And let's go to case 4 with Robert, this has also been a topic in the news, right? He is concerned because his family has plans, they're trying to conceive, and what's the risk to his wife? So there has been reported sexual transmission. As I said before, 2 cases where there was actual transmission, and 1 case where they found Zika virus or PCR positive in the semen. There was no actual transmission in that 3rd one. So what can we tell folks? We can tell Robert to use condoms upon his return. And of course, the main thing is discussing risks and benefits with the family. You know, how safe is this? We don't know. Like, what is the chance? We don't know. So it has to be a discussion. Do they want to proceed with trying at this time or not? Because as I said before, can the virus stay in the semen for more than 2 weeks? We don't know. We know at least 2 weeks. And what about males who actually live in endemic areas? Like, well, you're not going to go back to X, Y, or Z. So what we can do there is, again, the same discussion, safe sex if you're not planning to conceive, and for other many reasons, STDs, etc., and also use insect precautions. This is a snapshot summary of the Zika epidemic. We talked about all this. We talked about Latin America and Brazil and cases. We talked about the microcephaly link. We talked about link with Guillain-Barre. And so this is just a summary slide, so you have a snapshot view of what's happening. I'm going to go into my conclusions. So as I said before, 80% of people are asymptomatic, which can be a blessing or a curse, because if you're asymptomatic and you're pregnant, you don't know if you had it or not. So you have to test them either way with the right geographic exposure. It's usually a mild self-limited disease, with the main concerns being in pregnancy. There are associations with microcephaly, congenital CNS malformations, GBS, and ophthalmic complications in infants. The diagnosis, as we talked about, is very challenging. Sexual transmission has been reported. We need to consider chikungunya and dengue in the differential. Novel vectors emerging with the Albopictus, so there is a concern of possible transmission here in the U.S. Not right now because it's too cold, but possibly in the summer we might be running into this. And I think that is my last slide, so I will open for questions. Thank you.
As we mentioned, we wanted to have, we discussed it, we want to have a long time for questions and answers. There's a lot to say about this virus, but then Anu is ready to answer any question. Well, we start.
I have two questions. The first is, and this may not be answerable at this point, is do we have any idea of the attack rate or the microceph rate in the
So the question was, do we have an idea of attack rate in relation to microcephaly? So the truth of it is no. The problem is even the current estimates, even in Brazil, might have been overestimated. So now they're going back and looking at all those cases again. So right now we don't have an answer to that. The highest estimate was like 4,000 cases, but it's possibly closer to 2,000, 1,000, but we don't know the answer to that.
I would add that what we mentioned is that microcephaly is the tip of the iceberg. What is going to happen with babies that are going to be born
We don't know.
normal, then this is just...
Yes.
The other question I had is you mentioned about the possibility of transmission in
Mm-hmm.
has the Red Cross consider recommendations to
Um,
allow blood donation?
Not just yet, at least not that I'm aware of, but I think this will be coming very soon because even in the Yap Island outbreak, 73% of that population was actually seropositive for Zika. So yes. Okay, thank you. Yeah. In South America, I think you were asking about, yeah.
I think here's they're going to change the, if I
Right.
travel somewhere,
Mm-hmm.
there a period of time.
I'm pretty sure that is coming very, very shortly. Yes. It seems like the viruses, they incite the formation of the autophagosome, but somehow we don't know quite why. Somehow inhibit that step where there's the connection. So they can actually incite your body to make the little viral factories, but they don't allow the lysosome to attach. But we don't know exactly why that is. Yes. Mm-hmm. Mm-hmm. I'm not sure that we know that. So, yes. So again, the mortality rate is low. I think right now there may be 2 to 4 reports of death associated with Guillain-Barre. So the mortality rate is not, but of course it's catastrophic when it does happen. I think right now we don't have enough information to know what the incidence is related to Zika in the current outbreak in Latin America. We do know the 20-fold rise in the French Polynesian outbreak. Yes. All right. So that is a great question. So what are the reasons for the outbreak in Brazil? So it's a combination of things. I would say growing up, the fogging was a constant. They also had sanitation workers that would come to your home and check for any containers of open water and do that. Actually asked my parents just the other day, what's going on? Like, is the fogging not working? Like, oh yeah, they stopped doing that 5-6 years ago. So that's one thing. The other thing, a lot of the northeastern states are going through a water shortage right now. Very hot temperatures. All the water reservoirs are drying up. So water rationing is there, and people are collecting those 2 hours in the morning when they have water, they're collecting it in whatever container they can find. So if you don't have your sanitation workers going there, you're going to have all this breeding ground. Okay, so that's one thing. The other thing, the media, the whole media deal. So other strategies that are used in Brazil, and you all have probably seen this on social media, there's a larvicide called pyriproxyfen that is put in water, in sources of water. And what it does is it's a insect hormone analog. So what it does, remember the little larvae that was sticking on the surface of the water? So it actually stops it from developing into the adult stage. So therefore you stop the reproduction right there, because you're not going to have adults to reproduce. So they had started using this in Brazil probably last year. And so there was a big frenzy about, oh, this is the thing that's causing this microcephaly, and it's not, it's not the virus, it's this. I mean, to me, Zika recovered in a baby brain is pretty compelling evidence. However, am I saying that all of this microcephaly there is Zika? No. We don't know. There's a lot of other things going on in Brazil. So I think that is the key. So sanitation, vector control is the main thing. And what it's going to do to the Olympics is another great question. So there's a big push, obviously, now in Brazil to get this under control because of the Olympics. But I don't know how quickly that is going to happen, just seeing that 22 out of 26 states are affected.
We were discussing that there's no question that you have a full continent, you have all the Americas with millions of people that never been in contact with this virus. This virus just arrived to the continent. Then, you are going to have the spread, initial spread, that is going to be massive, regardless of what we're going to be doing. Then, as the virus establishes and people start developing antibodies for prior infection, who knows what is going to happen. But this is a new disease in the Americas. And we are all susceptible until we get the vaccine. Excuse me?
Yes.
Is there a reservoir other than infected patients? Kids with short illness,
right.
to get the lysosomes don't work and keep going. Is there a human reservoir, or if you can eliminate it long enough, if you say eliminate it?
That's a good question. You asked if there was another reservoir other than humans, correct? Not that we know of. Not that we know of so far, yes.
Again, the speculation at this moment is no. Right. We're not going to have any. Now, we know that it's in monkeys in Africa. Then we know that it's in animals. But it's not it has not been isolated from the horse, the pig, the animals that we interact, that other viruses can go to the animal, and then the mosquito goes to the horse and they come to us. This one is just, at this moment, it's only human. Again, as Anu mentioned so many times, the problem is that we don't know what is going to happen when the virus gets established here.
And I, go ahead, yes. You're supposed to be technically immune. Right.
Yeah. Mm-hmm. Yeah, there's no animal cycle.
Right.
This is human,
exactly.
mosquito, human.
We don't have evidence of that just yet, I guess.
Again, chronic human in the blood, even though we don't know in other areas.
Right, because like in semen, how long is it there? In CSF, how long is it there? We don't know. Yes. Oh, yes. They're live births. Like I said, not all cases of Zika in pregnancy are going to lead to microcephaly. And the spectrum of microcephaly is very large. It's not that all babies are going to have that grossly malformed brain that you saw in that autopsy. So yes, there are live births, and this is a whole nother problem, like Dr. Ramirez said, the tip of the iceberg, because these babies with these cognitive impairments, what is going to be the strategy for taking care of them? Yes. Anybody else?
I have to tell you that since also on the news, Obama just put $2 billion for research of this, and there are requests for animal studies to try to answer all these questions. And yesterday here there was Kenneth Palmer from the Center for Predictive Medicine put together a group that we will need to answer some of these early requests for application. And I have to tell you that Dr. Chan here from the Center for Predictive Medicine is an expert on flavivirus. And we already have 2 Zika viruses from the CDC. Some time ago, they are trying to grow the virus. They are developing some animal models. We are very interested from the group of the Center for Predictive Medicine to develop a good PCR, a good RT-PCR that we want to have in our clinic, because there's going to be a lot of patients returning that may want to be tested. And there's a lot of questions probably I want to be able to answer in our environment. But I would like to say that if you have any other comments or questions, Anu is always available. Well, Anu and Ruth, they are always available. But really, if you want to travel and you come into our travel clinic, it's going to be Ruth or Anu giving you the advice. Another thing that we're going to be doing is, as we speak, we are writing an IRB protocol for all our people that in our travel clinic to try to get blood before and after and other samples. We're going to keep this in our biorepository because they're also going to be working on some better antibodies. And as you know, Kenneth Palmer was the one that during the outbreak of Ebola, he put together some antibodies as therapeutic strategy. And they also were going to be looking at antibodies as therapeutic strategy. And there is a group here, IGOR, that work with dengue vaccine. Then there's going to be also some group working on Zika vaccine. Then there's going to be a lot of activity in basic science connected with us in doing clinical research in Zika. Then we want to that any question that you have, any clinical relevant question, you can please talk to us or send us an email. We are addressing this in this translational approach where our basic scientists here at the university. Any other closing remarks?
No, I just would want to urge everybody to be careful what they are saying on social media. There's a lot of things that have consequences, like the whole rumor with the larvicide and the genetically modified mosquitoes. That might be the best combination of things for vector control. And now even one of the states in Brazil has stopped using the larvicide because of this whole hubbub on the social media. So just look at the facts. Like, try not to make that into, because it does have consequences, especially if we want to control this epidemic. Thank you.